Hi team, Charmaine here. Welcome today to the Managing Fluid and Electrolyte Imbalance lecture for week -1 for the subject Nurse 5084, Nursing the Acutely Ill Person. This lecture today is going to have a clinical practice focus as part of this clinical practice unit, and we'll introduce you to IV or intravenous fluid therapy as part of managing fluid imbalance. This builds, of course, on the fluid balance tutorial that was delivered in Nurse 5082, which is still accessible through Canvas. I do encourage you to, if it's been some time since you visited this topic and reviewed this topic, to either go through the pre-reading or go back to that lecture recording that Jane has put up on Canvas. She's got her PowerPoint or PDF format presentation available for download, and also because this year, because of COVID, she has recorded her voice to go with that presentation, so you can have a listen to that and revisit that before you continue. The focus of this lecture is on the nursing care that is associated with caring for a patient who is clinically deteriorating, and then as part of managing this, we are going to apply our knowledge of safe administration of IV fluid therapy within our current scope of practice. So before I continue, I'd like to acknowledge and pay respect to the traditional owners of the land on which our lectures are conducted or recorded, that is the Gadigal people of the Eora Nation. It is upon their ancestral lands that the University of Sydney is built. So we pick up, as I said, from Nurse 5082. The tutorial at that time looked at fluid balance, as opposed to today where we look at fluid imbalance and how we can manage that. That tutorial also looked at what fluid balance actually is, the role of the kidneys in fluid balance. We explored body fluid composition in that tutorial, passive and active transport, as well as osmosis. We looked at third spacing, input and output, and we introduced you to the fluid balance chart as part of that. And of course, we'll be looking at fluid balance charting and continuing that this semester in 5084 with all of our administration of intravenous fluids. In that tutorial, we went through the assessment of fluid input and output, how we know if a patient is dehydrated, how we know if they're fluid overloaded, and also the relevant laboratory studies, and that included the blood tests of electrolytes, urea and creatinine, the EUC, full blood count or FBC, specific gravity, and of course you looked at urinalysis in 5081. So that was where we pick up, and at the end of this lecture, this is where we hand over to. We will hand over to 6018 and 6019, which is a first semester final year unit. So for most of you, it will be first semester of next year if you're not part-time. And in 6018, it's a chronic care condition subject. And in that subject, you'll look at subcutaneous infusions of fluid in the context of palliative care. And that's known as hypodermoclysis, the administration of fluids into the subcutaneous layer of the skin. And that allows fluid to be absorbed into the circulatory system through the extensive subcutaneous lymphatic and blood vessel network. It is used for short-term hydration in mild to moderate hypovolemia in adult patients who are unable to adequately tolerate oral fluids or where it's impractical or difficult to insert an IV line, so often in palliative care contexts. Also, we hand over to 6019, that is usually taken concurrently with 6018. 6019 is a high acuity unit. In that subject, you look at central venous access devices as opposed to 5084, this subject, where you look at peripheral venous access devices or cannulas. In that subject, you look at peripherally inserted central catheters, so those two are going into a central vein. Other access ports that are quite invasive and appropriate for high acuity areas such as HDU, ICU, and ED. You look at blood administration and total parenteral nutrition, or TPN. In that unit, you also look at acid-base imbalances. So again, you build on your knowledge from 5082 with fluid balance. You build on 508 for this subject with fluid imbalance, and you go and you look further into acid-base imbalances, which is more often an issue that is dealt with in high acuity areas. So that's just to sort of give you an idea of how your content with regards to fluid balance, fluid and electrolyte imbalances are scaffolded throughout your degree. So what we're looking at specifically today is fluid and electrolyte replacement, access sites, specifically the peripherally inserted peripheral IV cannulas, categories of fluids and fluid prescription types, and I always like to highlight the relevance or the practical relevance of the content that you're learning in preparation for your clinical placement and your future practice as a registered nurse. So we're going to be using our knowledge in the context of a patient case scenario. Before we go into some context, some concepts around fluid imbalance, I want to look at the evidence around why knowing how to apply our knowledge with regards to fluid balance and fluid imbalance is so important. And I always like to start with what the research is around this area. So there was a recent study that investigated final year nursing students' use of something called situational awareness when making clinical decisions about patients' progress in clinical care. So why is situational awareness so important? It's an important precursor to making decisions that are linked to clinical outcomes or improved clinical outcomes. But there's not a lot of but the evidence that is there is actually suggests that nursing students don't feel adequately prepared to make clinical decisions. So the study that I've put a quote from on the screen is from a study that outlined 3 levels of situational awareness with regards to final year nursing students. And so the tenets of this framework around situational awareness stems from the argument that in order to make effective decisions, the decision maker needs to identify important cues and have a sense of what's really important. This includes understanding what's happening currently to the patient, as well as being able to project how the current situation might influence the near future. So how might, what the current patient situation is and how might this progress? Will the patient potentially get worse? What might the treatment be if the patient's condition gets worse? Might they get better if I do this, and that kind of thing. So being able to preempt a lot of what might happen and have contingencies in place. So of course, being able to project how the current situation might progress in the near future or influence the near future, this has important implications in patient care and planning and preempting, of course. So there is 3 levels of situational awareness outlined in the research, and it ranges from information gathering at the most basic level, and so that includes monitoring, collecting cues from your A to G assessment, simple recognition, for example, monitoring of vital signs. Errors, of course, occur at this level when data is either not available because it hasn't been collected or it was misinterpreted. The next level of situational awareness relates to the interpretation and synthesis by combining the cues and then understanding how it might impact on a situation and also how significant this information is. So starting to interpret the vital signs, starting to put them together. It's not just about that level 1 situational awareness of collecting it. Level 2 is saying, actually, this patient is hypotensive, and and their heart rate has been steadily increasing. And what might this mean if I start to put this, and this together? And how might this progress into the future? What will I need to do now in order to prevent that from happening? And what can I do to prepare in case it does happen? So it's about that, projecting a trend in vital signs might eventuate in harm to a patient. Level 3, situational awareness, develops from knowledge and comprehension that when combined, the decision maker determines the possible outcomes. In this study, 12 final year nursing students were recruited to participate, and overall the students felt very unprepared to process the situational awareness that's required for clinical decision making. And that's what I've got on the screen, that quote that sort of demonstrates, just with regards to fluid imbalance. Students were less sure of the cues that matched expected patient progress related to intake and output. They relied on isolated data that was recorded on specific charts, for example, the vital signs chart and the fluid balance chart, and they struggled to bring the different data together to provide a more robust approach to decision making about how their patient was progressing. They didn't think about the other cues related to physical assessment that might have informed their decision making about a patient's fluid balance, for example, skin turgor. So this is where putting your A to G together comes into play, and learning to apply it, becoming more proficient with it, and not being afraid to put that into practice when you are on clinical placement, because that's the time to put it into practice, and that way you'll become more proficient over time and exposure to these situations. So the multidisciplinary management of fluid and electrolyte imbalances, we often classify them as either fluid deficits or excesses. And managing a fluid volume deficit involves correcting, of course, the underlying cause and then replacing both water and any needed electrolytes. Replacement therapy depends on the severity and type of volume loss. In mild losses, oral rehydration might be sufficient. If the deficit, though, is more severe, then the volume is replaced with either blood products or balanced IV solutions, and we'll most commonly use 0.9% sodium chloride, also known as normal saline. The choice of fluid, of course, depends on the cause and the patient's electrolyte status, and for rapid volume replacement, normal saline is preferred, and when blood blood can be administered when volume loss is due to blood loss. When it comes to fluid volume excess, it still involves treating the underlying cause and removing fluid without producing any abnormal changes in the electrolyte composition of the patient's extracellular fluid. So it might involve diuretics and fluid restriction as some primary forms of therapy when it comes to managing fluid volume excess. Some patients also need sodium restrictions in their diet, and you might have seen that occur on clinical placement. So the nursing responsibilities in terms of fluid and electrolyte imbalances. So we looked at multidisciplinary, the role of the multidisciplinary team. But specifically with the nursing responsibilities, we're looking at a restriction of fluids. So patients who retain fluids have that fluid volume excess, and they require restricted fluid intake. That restriction is often difficult for patients, especially if they take medications that dry the oral mucous membranes, or they breathe through the mouth and experience that sensation of thirst. So the nurse, you as the nurse, should really explain why the fluids are restricted and the amount of fluid that is permitted orally. And that could mean that they can have ice chips, jelly, ice cream, and other certain foods or fluids, but they need to know that is considered as fluid. Those ice chips, the jelly, the ice cream, and that kind of thing. So it's not considered food. We have to add that to their fluid restriction and their fluid balance. The patient should help to really decide how much fluid they're going to have when they're on a fluid restriction, in terms of how much they're going to have with each meal. So a good rule of thumb generally is for fluid restrictions to be, to allow half of the allotted total oral fluid between 7 in the morning and 3 in the afternoon, because that's the period of time when we're all really more awake and active, and we have 2 meals of the day during that time, and and patients take most of their oral medications during that time. So if they're on a 1.2 liter fluid restriction, then we'll discuss that with the patient, negotiate with them, let them know that that includes jelly, ice cream, ice chips, and that kind of thing, and advise them that they can have. It's probably best to have half of that, so 600 milliliters of that fluid restriction within the time of 7 in the morning to 3 p.m. and see how that works for them. And so involve them as much as possible in their care and decision making of their care. Patients on fluid restrictions require frequent mouth care to moisten those mucous membranes, and that will decrease the chance of that mucous membrane drying out and cracking, and it also maintains patient comfort. Daily weights are the most accurate measure of volume status. An increase of 1 kilo is considered equal to 1 litre of fluid retention, provided that the patient has maintained a usual diet and hasn't been on any nil by mouth status. When we weigh patients daily, we take the weight under standardized conditions. So we weigh them at the same time every day, wearing the same clothes, so they're usually their patient gown, and on the same weighing scale. Fluid balance charting, intake and output records, they provide that valuable information about fluid and electrolyte problems. So an accurately recorded intake and output is going to identify sources of excessive intake or fluid losses. Intake should include oral input or oral fluids, IV fluids, and output includes urine, wound or tube drainage, and any time someone vomits or has diarrhea. So we note the amount and color of the urine as part of that, and measure the urine specific gravity, which you learned about in Nurse 5081. When it comes to physical assessment and vital signs, we monitor vital signs and perform our A to G assessment. In fluid volume excess, we might find that the patient's pulse, when palpated, feels very full and bounding, as we would describe it. It can also cause distended neck veins and a high blood pressure measurement. In mild to moderate fluid volume deficits, the sympathetic nervous system compensates and increases the heart rate and results in peripheral vasoconstriction. And that's in an effort to maintain blood pressure within normal limits. So pulses might be palpated and described. When you palpate a patient's pulse at this time of fluid volume deficit, pulses might be weak and thready, and we should also assess for any postural changes. And that what I mean by that is a patient's change in position from lying to sitting or standing might elicit a decrease in blood pressure. And in more severe deficits of fluid, hypotension might be present. We also monitor the pulse oximetry and auscultate lung sounds. Extracellular fluid excess can actually result in pulmonary congestion and pulmonary edema, as increased hydrostatic pressure in the pulmonary vessels will force fluid into the alveoli in the lungs. The patient then experiences shortness of breath and moist crackles on auscultation. The patient with a fluid volume deficit can demonstrate an increased respiratory rate because of decreased tissue perfusion and then resultant hypoxia. In this case, it's likely that the patient will require the administration of oxygen through a prescription. And that's something that we covered in Nurse 5082. Skincare is important. So we look at skin turgor. Normally a fold of skin when it's pinched and we look at skin turgor on the back of the forearm or the sternum, will readily move, and then when you release it, it will return to its former position. But in patients with a fluid volume deficit or an extracellular fluid volume deficit, the skin turgor becomes diminished, and there will be that lag in the pinched skin folds return to its original state, and we term or refer to that as tenting. Just keep in mind that in older patients, decreased skin turgor is less predictive of fluid volume deficit because of the normal physiological changes of aging where they have that loss of tissue elasticity. In mild fluid volume deficits, the skin can appear warm, dry, and wrinkled, and these signs might be difficult to evaluate in the older person because their skin may be normally dry, wrinkled, and non-elastic. In more severe deficits, though, the skin might be cool and moist if there is vasoconstriction in order to compensate for the decreased fluid volume. Oral mucous membranes will be dry, the tongue will be furrowed, and you'll see these fissures in the tongue. And the patient will often complain of thirst as well. Edematous skin might feel cool because of the fluid accumulation and a decrease in blood flow secondary to the pressure of the fluid. The fluid can stretch the skin, causing it to feel quite taut and hard, and you might also see that it becomes very shiny, the surface of the skin where it's stretched. And so you assess edema by pressing the thumb or forefinger over the edematous area. And we need to really protect edematous skin from extremes of heat and cold, prolonged pressure and trauma. So there needs to be frequent skin care and changes in position in order to prevent skin breakdown. Ideally, we elevate edematous extremities in order to promote that venous return and fluid reabsorption, and the application of moisturizing creams or oils can help increase moisture retention and stimulate circulation, and just help protect the skin in general. Patient safety with fluid volume deficits is with regards to falls because of that postural hypotension that I mentioned earlier. This also can be a muscle weakness and changes in level of consciousness. So we assess the level of consciousness, the patient's gait and muscle strength. Let's also have a look at their falls risk, which you learned about in Nurse 5081. And if there is postural hypotension, we need to educate the patient to change position slowly when they're rising out of their bed, sort of sit on the edge of the bed first, move your feet and ankles around, get the blood flowing, and then take some deep breaths and see if you can stand up just right next to the bed, and don't continue walking until you feel quite steady on your feet. And if it's really a risk, then the nurse should be there present when this happens. So now we look at cannulas, and we're going to talk about this more in depth in the theory portion of your clinical simulation laboratory presentation that will help prepare you for your actual lesson. But just so that we can introduce it now, a peripheral intravenous catheter, or PIVC, or cannula, it's a small flexible tube that's inserted through the skin and into a peripheral vein. And this is going to allow for the administration of a range of therapies such as medications and fluids directly into the bloodstream, which otherwise can't be given or might be less effective if given by other ways such as through the mouth. So the insertion of a cannula is one of the most common clinical procedures performed, with up to 70% of hospitalized patients requiring a cannula at some point during their hospital stay. Studies estimate that actually 4 to 28% of cannulas inserted are not actually used. Australian studies report that this is even higher in emergency departments, where about 50% of cannulas that are inserted aren't used, and that unnecessarily places patients at risk of infection. So despite their frequency of use, cannulas are reportedly associated with complications up to almost 70% of the time, and those complications can include blockage and dislodgement, redness and swelling of the vein, and infection. So unfortunately, not all attempts to insert cannulas are successful. Nearly half of all first insertion attempts fail, and this causes undue pain and anxiety for patients, of course, when someone's inserting a needle into your tissue and trying to get into a blood vessel. And it can result in multiple failed attempts. To reduce rates of complications associated with cannulas, we use best practice guidelines and recommend a range of strategies. Despite best practice data that's available, we still know that the evidence shows that there is a significant proportion of patients who don't receive care as recommended in order to optimize the use of cannulas. And actually, the Australian Commission on Safety and Quality in Healthcare is currently in the process of developing a clinical care standard, similar to what we have with regards to falls risk, with regards to what we have with clinical deterioration, infection control, and those kinds of things. They are developing a clinical care standard around the use of cannulas, just so that we can have more consistent, high quality standard of care. So fluid and electrolyte therapy, in the scope of Nurse 5084, we're looking at we're starting to look at parenteral routes, and that's any route that's not going through, that is sort of bypassing the GI tract or gastrointestinal tract. We have crystalloid, the category of crystalloid fluids, which involve fluid and electrolyte replacement. The most common example is normal saline or sodium chloride 0.9%. It's the most common isotonic fluid. We also have colloids, which are blood and blood components as part of intravenous fluid replacement, and that is looked at in Nurse 6019 next year in high acuity nursing. So we're giving IV fluid replacement through the vascular access devices like cannulas, as I've described, and fluid and electrolytes this way can be replaced directly into the bloodstream rather than the digestive system and through infusion. It's necessary to treat many different types of fluid and electrolyte imbalances through IV fluid and electrolyte therapy. And many patients need maintenance IV fluid therapy when they can't take oral fluids. The most common example that I can give you that you'd all be familiar with is when patients are undergoing surgery or even after surgery, because, from 5082, patients are often fasting. Other patients need corrective or replacement therapy for losses that are ongoing or have already occurred, and the amount and type of solution is going to be determined by the normal daily maintenance requirements of patients and by imbalances identified by the laboratory studies, something that was outlined in Nurse 5082 in the tutorial. IV replacement solutions are classified by their concentration, and that's an important factor in determining the appropriate solution to correct imbalances. So the goal of IV fluid therapy is to correct or prevent fluid and electrolyte disturbances. It's going to allow for direct access to the vascular system, and it permits the infusion of continuous fluids over a period of time. We just need to closely regulate and monitor what's happening to the patient when they're on IV fluid therapy because of those continual changes in the patient's fluid and electrolyte balance. So as we can see with the slide, crystalloid solutions such as normal saline, crystalloid solutions contain small molecules or solutes that are able to easily cross semi-permeable membranes and therefore transfers from the bloodstream into the cells and body tissues. When IV fluid administration is required, we need to know the reason for the prescription. So why is the patient having the fluid? Why are they having this particular solution and this particular volume? We need to know about what is the equipment that's needed, the procedures required to initiate the infusion, how to regulate the infusion rate, and all these practicalities we go through in the presentation to prepare you for your simulation lab session, and then you actually get to put this into practice during your lab in week 1. Crystalloid solutions such as normal saline are really the go-to fluids on the wards for volume expansion and replacement of poor oral intake. It's typically the most appropriate solution because it's appropriate for a lot of different uses, and there's really very few medications that can't be mixed with it. The danger with too much normal saline is that it has a high sodium concentration. It is sodium chloride, and the sodium concentration in normal saline is 154 millimoles per litre, so that's somewhat higher than that of plasma, which is about 135 to 145 millimoles per litre, and a chloride concentration of 154 millimoles per litre. That is significantly higher than the plasma chloride level, which is 96 to 106 millimoles per litre. Therefore, if you have an excessive administration of normal saline, it has the potential to increase sodium and chloride levels. And so generally, patients really should not have more than 3 to 4 litres of normal saline within a 24-hour period. So many of these prepared IV solutions, we've got on the slide a list on the left of different types of IV solutions. They include whether they are isotonic, hypertonic, or hypotonic in concentration. Isotonic solutions have the same osmolality as body fluids. Hypotonic solutions have an osmolality less than body fluids, and hypertonic solutions have an effective osmolality greater than body fluids. So in general, isotonic fluids are used most commonly for extracellular volume replacement, such as the fluid replacement that's required after prolonged vomiting, for example. The decision to use whether it's a hypotonic or a hypertonic solution is going to be based on specific fluid and electrolyte imbalances. A hypotonic solution has more water than it has electrolytes, so the osmotic process then produces a movement of water from extracellular fluid to the interstitial spaces and cells, and this causes cells to swell. So hypotonic solutions cause cells to swell. A hypertonic solution, through having a higher osmotic pressure, draws water out of the cells and into the extracellular fluid. So hypertonic solutions draw water out of the cells. This is why we usually sit most commonly in the isotonic space. So an isotonic solution having a similar concentration of water and electrolytes to plasma. Because of the similarity, we administer this isotonic fluid in order to expand extracellular fluid. And that way, the fluid doesn't move into the cells, it doesn't affect our cells, it doesn't draw water into our cells, it only affects extracellular fluid and therefore doesn't dilute our plasma. That really makes isotonic solutions the ideal fluid replacement for patients with extracellular fluid volume deficits. So other examples of isotonic solutions that are really common, aside from normal saline, are Hartmann's and also plasmolite, something called plasmolite. Hartmann's is something that you'll see most often post-operatively. This is 98% of our patients who come out from operating theatres and into recovery have Hartmann's going through. So we use isotonic normal saline when a patient has experienced both fluid and sodium losses, for example, when they've experienced gastroenteritis, they've been experiencing diarrhea or vomiting. And when we give a patient Hartmann's solution that is, again, isotonic, it contains a mixture of sodium, potassium chloride, calcium, and lactate. So it's about, the concentration is about the same as extracellular fluid, and that way, and that makes it the ideal fluid in certain situations such as surgery, burns, or gastrointestinal fluid losses as well. How much to replace? A general guide for the amount of fluid required in a healthy adult is about 30 milliliters per kilo per day. If, for example, a patient weighed 50 kilos, they would require 30 milliliters multiplied by 50 kilos, and that would equate to 1.5 liters a day. And then to obtain the hourly fluid intake, that would need to be divided by 24. You can also calculate the hourly fluid maintenance by using the 4-2-1 method, and this is similar to what's used in pediatrics. It's 4 milliliters per kilo for the first 10 kilos, then 2 milliliters per kilo for the next 10 kilos, and 1 milliliter per kilo for the remaining kilos or kilograms. So if a patient weighed 60 kilograms, their 24-hour intake would be, according to the 4-2-1 method, would be 40 plus 20 plus 40, and that would equal 100 milliliters per hour. Determining the appropriateness of how much urine output a patient has is also an important assessment. So we need to be aware of the expected urine output based on gender and weight, and so we know from last semester that it's generally 0.5 mils per kilo per hour that we're looking at. But if you really want to be more specific, you can use that general rule of that 0.5 mils per kilo per hour for males and 0.4 mils per kilo for females, if you want to be more specific. That's the minimum urine output that's required in order to ensure adequate renal function and to be able to eliminate the waste products from the body. A general rule is that urine output indicative of adequate renal function should be equal to or more than 30 mils per hour, but it's only a general guide, and if you don't use that more sort of accurate one of 0.5 for males and 0.4 for females per kilo per hour, then it can lead to over or underestimation of the adequacy of urine output. So if you have, for example, a male who weighs 65 kilos, then the expected urine output would be 34 to 35 mils per hour. And for a female weighing the same weight of 65 kilos, it would be 26 mils per hour of urine output. We usually assume, you would have noticed that on clinical placement that most inpatients are having IV fluids during their inpatient stay. And there is a lot of assumption around patients being at risk of fluid and electrolyte imbalances because they're in hospital for a reason. So it is quite a common nursing aspect of nursing care. Some of the common terms that you'll hear with regards to fluid prescription types and terms are the following on the slide. So when we refer to an IV infusion, it's a large amount of fluid that's being administered to a patient over a specific time frame, and it's not just a once-off. I'm pushing in the medication, or I'm pushing in 10 milliliters of fluid, or I'm pushing in the medication. I'm injecting it over 30 seconds, 10 seconds. That would be a bolus or an injection, and that's not an infusion. Infusion is a large amount of fluid going in over a certain time period, so it's not quick. Not usually quick. Usually it's 15 minutes or over when it comes to an infusion. You might also see or hear them saying, give them a bolus or give it stat. Stat means, of course, right away, and bolus is that bag of fluid that's allowed to run through its natural state. So when you have a listen to the theory behind IV fluid administration for your lab in week 1, we'll talk about the release of the roller clamp, and that opens and closes and control the flow rate of the fluid, and it regulates the flow rate of the fluid. So when you have a bolus, it's a bag of fluid that's allowed to run through its natural state. So you open the roller clamp, there's no there's no regulation of fluid, you just let it run. And that will take about 15 minutes to completely run through. Those are often written as up as stat on a fluid prescription chart, and we'll go through what these pieces of documentation look like in the presentation that prepares you for your simulation lesson in week 1. You might also hear or see the term fluid resuscitation or fluid resus. This is when IV fluids are administered in order to rapidly maintain, replace or restore intravascular volume in patients who are in shock or severely hypovolemic. And that might look like 1 litre of normal saline infused stat. So that's going to go over 15 minutes. And then it's followed by 1 litre of normal saline to go through over 1 hour. And so it can be a regimen. Fluid challenge is another type of prescription you might see or hear. IV fluids, this is when IV fluids are administered to see if a patient who is hypotensive is responsive to having that quick infusion of a large amount of fluid. So if a patient is moderately hypotensive and maybe therefore we're presuming that they're underperfused, that patient will receive 250 ml as a bolus, and this will be to fluid challenge them to see if that hypotension is going to be responsive to that fluid. In other words, will their blood pressure start to increase as a result of delivering 250 milliliters of fluid over 15 minutes. If it partially rectifies the hypotension, then a further 250 mils can be given, followed by a 1 litre bag going over 4 hours, and then we slowly move them to a 1 litre bag over 8 hours and a 1 litre bag over 10 hours in order to just then maintain their fluid balance. Fluid replacement therapy is going to be necessary when either the effective circulating volume is depleted or their electrolytes require correction, which is why we do those blood tests for patients who are on fluid therapy. If the patient is dehydrated or only mildly hypovolemic, then that aggressive fluid replacement is not really necessary. Instead, fluids should be administered at a slightly slower rate, and that way we can ensure that the volume that is given is greater than their daily requirements and any concurrent losses. So a typical regimen for a mildly hypovolemic patient would be a 4-hourly litre bag of normal saline or Hartmann's, followed by a 6-hourly bag and then a bag going over 8 hours, and that will help to increase their circulating volume back to their baseline. When we maintain fluid balance, a maintenance fluid regime can just be what their normal intake would usually be. So remember to use that guideline, that 4-2-1 rule that was on the previous slide. We might also be using maintenance fluid therapy for patients who are fasting or have poor oral intake. If a patient is fasting for more than 8 hours, and some of you I know have seen this on clinical placement, some patients fast to prepare for surgery, and then their surgery is postponed or cancelled, and they can be just waiting for extended amounts of time and that they weren't able to really plan for or preempt. So it's good practice to replace their oral intake with intravenous fluids in order to prevent the patient from becoming hypovolemic and experiencing that discomfort of thirst. And patients who have bowel preparations to help clear their intestines before surgery, that can be very dehydrating. And so this is an example from a particular facility of their guidelines for adult intravenous fluid therapy. And this is just to give you an idea, but not all hospitals have something like this. So their first step is to assess the patient, of course, A to G assessment, and then trying to look if the patient is hypovolemic, euvolemic, or hypervolemic. And so they have some guidelines here. If the patient is hypovolemic, you might see that their systolic blood pressure is 90 or less, heart rate of over 90. They might have cold hands and feet, a cap refill of over 2 seconds, a respiratory rate of over 20 breaths per minute. They're oliguric and have a decreased level of consciousness. It's just a general guide, but in that situation, they want you to resuscitate, replace, and maintain in that order. Euvolemic patients, their blood pressure and heart rate are of course normal. They're in that normal state. They've got warm hands and feet. They've got good circulation. The veins are well filled. They've got a capillary refill of less than 2 seconds, and their urine output is adequate, being at more than 0.3 mils per kilo per hour. In this situation, we're just going to replace any losses that might occur and keep them on some maintenance, so maintain their fluid balance. In patients who are hypervolemic or fluid overloaded, you might see peripheral edema, pulmonary edema for reasons why we already spoke about, elevated jugular venous pressure, weight gain, a history of renal impairment, and a positive fluid balance on their fluid balance chart. In this situation, we want to limit their volume and limit their sodium, either in their fluids or their diet. Their second step after this assessment and this very general guide is to review their bloods. And so EUC, your urea, your electrolytes, urea and creatinine. Have a look at your comprehensive metabolic panel, which is a comprehensive, it's used as a screening tool to evaluate the health of organs. It's a group of about 14 different tests, and they measure several different substances in your blood. It's a quite common test to have done too. Do daily weights on a patient and look at their fluid balance, basically, and consider, does the patient really need intravenous fluids? Here's the guide for what's going to happen when patients are having a fluid resuscitation. So large bore IV access, so quite a wide diameter for a cannula, and they're going to give it that rapid bolus of 500 milliliters to 1 liters of normal saline. The priority is to stop any bleeding, rapidly restore the hemodynamics to become stable, and if it's sepsis, they'll need to treat that or do further investigations. To replace ongoing losses of fluid and electrolytes, there's another guide there. Assess the extent of ongoing losses, such as vomiting, diarrhea, drain output, etc. Prescribe in addition to routine maintenance, which is below, and you will need to seek senior advice for appropriate fluids. And so if it's a junior medical officer, they'll need to speak to their resident. Providing maintenance fluid looks at about 25 to 30 milliliters per kilo per day, at a maximum rate of 100 milliliters per hour. And so they just gives a good general guide of what you can expect when it comes to adult intravenous fluid therapy. So let's look at a patient case study now. So you're the registered nurse looking after this patient, who is Peter Blakehurst. And ideally by the end of this session and this patient case study, you'll be quite confident in the range of a normal urine output, be able to identify accurate assessment and documentation of urine output and fluid balance, and be able to identify early and late warning signs of deterioration, specifically with regards to fluid imbalance. So Peter is a 48-year-old male who lives at home with his wife. He had an emergency laparotomy for a diverticular abscess 2 days ago. He has had his IDC removed yesterday morning, and his first void, so he's being able to pass urine after having that catheter removed, was 150 milliliters. He's got a history of type 2 diabetes, hypertension, with a normal blood pressure of 140 on 95. He's morbidly obese at a weight of 125 kilos. Medications, he takes oral hypoglycemics and antihypertensives. So again, you are the RN. We'll say, for example, your nurse is Andrew. So RN Andrew. You start your afternoon shift in a surgical ward at 2 o'clock in the afternoon, 1400 hours, and the bedside handover commences with bed 3 and Peter is in bed 10. You'll be working with another nurse and you are assigned 10 patients, and this includes Peter. I want you to keep in mind the additional calling criteria, not just the ones for the vital signs in the middle of the SAGO chart. This is what's on the back, and this is following on from our first lecture, which was applying A to G assessment. I want you to focus on the ones regarding fluid balance, about low urine output. So low urine output that is persistent for 4 hours, and that is less than 100 milliliters over 4 hours, or if they have an IDC, less than 0.5 mils per kilo per hour. And keep in mind the additional red zone criteria, which is low urine output persistent for 8 hours. So that means less than 200 milliliters over 8 hours, or less than 0.5 mils per kilo per hour if they have a catheter in situ. So with his SAGO chart here, you can see Peter Blakehurst is the patient, and it's now 2 o'clock in the afternoon. The vital signs were last taken at 12:40. It can be a little bit difficult to see, but this is the time of 12:40 in the afternoon. The rest rate is 14. The oxygen saturations are 29% on room air. The blood pressure is 130 on 70, and the heart rate is 95 beats per minute. He is alert. His temperature here indicates a temperature of 37.2, and because he's got that history of diabetes, they last took his glucose level at 6:30 in the morning, and it was 5.2, so quite some time ago since they last took his glucose level. Here's his fluid balance chart. It shows oral input and output. There are no IV fluids running. Currently, he has had 640 mils total in today, and a total of 210 milliliters out. Between the time of 6 o'clock in the morning and 10 o'clock in the morning, he therefore has had a urine output of 100. So do you have any concerns about Peter? When you were doing as RN Andrew, while you were at Peter's bedside for handover, you have a look at his SAGO chart, and all his previous obs are in that white zone there between the flags. You also check his fluid balance chart that we've just had a look at. So are you concerned at all about his current condition? So ideally you would have said yes, Peter's healthcare records indicate a low urine output, which is an early sign of deterioration, and listed on the SAGO chart within the additional yellow zone criteria. The reason why the ones at the top are incorrect are because while Peter's observations are between the flags, his healthcare records indicate that low urine output, which is an early sign of deterioration, as I said, and is an additional yellow zone criteria. If you are concerned about a patient, you should always talk to the nurse in charge, so the team leader. But you should first complete a full set of vitals and an A to G assessment before you do so. That way you'll have a good ISBA for your team leader or your nurse in charge. The same reason why the top answer is considered incorrect, while Peter's observations are between the flags, we've got that low urine output, which is an early sign of deterioration and an additional yellow zone criteria. So how are you going to now evaluate Peter's condition? Are you going to perform a bladder scan? How much and ask the patient how much urine he's passed? Are you going to discuss your concerns now with the nurse in charge and identify a plan? Or are you going to complete a full set of vital signs and an A to G assessment? Or go straight to the admitting team of medical officers and discuss your concerns with them? So especially now that you've noted that the urine output has met the clinical review criteria, how are you now going to evaluate his condition? So it would be most appropriate to do a full set of vitals and an A to G assessment, so an updated one. While you could perform a bladder scan or ask how much he's passed, a full set of OBS and an A to G assessment should be completed in order to identify any further early or late signs of deterioration. Before you go ahead and discuss your concerns or condition of the patient with the nurse in charge, you should have your full set of vitals and an A to G assessment ready to be able to report that to them through an ISBA handover. And similarly, before you talk to the medical officer, the admitting medical team, you want to be able to say what the patient's current condition is very thoroughly and accurately. So what are those warning signs in terms of yellow zone criteria and late or rapid response criteria? So where would a low urine output persistent for 4 hours go? Where would that be an early sign or a late sign? Would it be additional calling criteria for a clinical review? Would it be additional calling criteria for a rapid response? Where would a low urine output persistent for 8 hours go? Again, is it early or a late sign? What about poor peripheral circulation? Because that's also an indicator. Where would that go? Is that an early sign of deterioration or a late sign? Is it an additional yellow zone criteria or an additional red zone rapid response criteria? What about polyuria in the absence of a patient who would be taking diuretics? Resulting in a lot of urine output. So if they're not on any diuretics or medications that, help them to pass large amounts of urine, are they experiencing that? So that would be a urine output of over 200 mils in 2 hours. So where would that sit? Is it an early sign or a late sign, do you think? Where would these sit? So the correct answer would be that the low urine output persistent for 4 hours is an early sign. Poor peripheral circulation is an early sign. And polyuria in the absence of the diuretic medications is considered an early sign. The only late sign with regards to those options is the low urine output persistent for 8 hours. And so this is a good test of your knowledge. And have a think if our current case study patient, Mr. Peter Blakehurst, displays any of these signs or symptoms. So Peter's current A to G, he is able to talk to you. He's got a rest rate of 19 breaths per minute. There's no accessory muscle use. He's got equal air entry, equal rise and fall of the chest. His oxygen saturations are 97% on room air. His blood pressure is 110 on 62, a heart rate of 107 beats per minute. It's regular in its rhythm, and he's got cool peripheries. He's currently alert and orientated and scores an alert or an A score on the AVPU. He's got an abdominal drain and it remains in with minimal drainage. His wound is intact and there's no new bleeding. He's got old blood stains on the dressing and a temp of 36.9, so he's afebrile. He's on a light diet, tolerating oral fluids. He says he's had 5 cups of water and 2 cups of tea today. He has tried to pass urine this morning, but it's only been able to pass a very small amount. So have a think about, between the hours of 6 a.m. to 10 a.m., he's only passed 100 milliliters of urine. His glucose level, he is diabetic, is 4.8 millimoles per litre. So what interventional treatment could you take? Do you think that treatment is not necessary at this stage, that maybe we could just change his position, or maybe we'll just give him some supplemental oxygen? Should he have an IV cannula inserted if he does, if he doesn't have one already? So hopefully you decided that Peter needs a cannula inserted to give access to his peripheral veins if he, since he doesn't have one already. Supplemental oxygen at this stage would not benefit the patient, and remember that the patient is ambulant, he's able to pass urine in the toilet, and that's the best position to attempt to pass urine, to be able to sit on the toilet, not use a bedpan, I mean. Peter's urine output indicates a clinical review that may be needed, and so treatment must be considered. So what are your next actions now? Are you going to increase, what are your next actions now, because you've initiated the appropriate clinical care based on your evaluation? So what are you going to do to next to manage his condition? You could increase the frequency of observations, reassure the patient, and document all events in the healthcare record. So just increase the frequency of the vital signs and leave it at that. Discuss his condition with the nurse in charge and repeat his OBS and document in the healthcare record. Continue routine OBS as his OBS are in the white zone or between the flags and reassure the patient. Or call the intern responsible for Peter and request that they review his situation when available on the ward. So first, we want to discuss the condition with the team leader or the nurse in charge, as the patient has 2 clinical review criteria with poor peripheral circulation and low urine output. So the nurse in charge needs to be informed, vital signs repeated in 30 minutes and the frequency of vital signs increased. From there, then you can determine what to do next. So with regards to this last one, in case anyone thought we should jump to this one, there are signs of deterioration. So he had that poor peripheral circulation and low urine output. So first you should inform the nurse in charge as part of your local clinical emergency response system or SIRS system in order to discuss and identify if a clinical review is required. And in this situation, sorry, I'll just get my face out of the way. In this situation, a clinical review is called, the responder arrives and asks you what is wrong with Peter. So how would you hand over in ISBAR format? So ideally you would start with your introduction. So you would say, hi, I'm Andrew. I'm the nurse looking after Peter today. He's a 48-year-old male. What would your situation look like? Would it be Peter is not well at the moment and has 2 clinical review criteria? The last void was 150 mils last night following removal of his catheter. Would it be Peter has not passed much urine this morning and needs a catheter? On assessment, he has cool peripheries. Would it be Peter is 2 days post-op following an emergency laparotomy? He's only voided small amounts of urine since last night? Or would it be Peter's urine output is less than 100 milliliters over 4 hours? His last void was 100 mils at 10 o'clock in the morning, and on assessment he has cool peripheries. Which of these best describes the situation? So it would be the last one. The first one, you would need to be more specific with the reasons for activating the clinical review. The second one, Peter requires an assessment to identify the causes of low urine output and cool peripheries. The third one, this information should be included within the background of ISBAR along with his relevant past medical history. And so what best describes the situation is currently the last one, which is that his urine output is less than 100 mils over 4 hours, because that directly makes it very clear that this is additional yellow zone criteria. You've outlined that the last void was 100 mils at 10 o'clock, and so you're accurate referring to the fluid balance chart, and you've done your A to G assessment, and the related concern is that he has cool peripheries. The background would then be that Peter is 2 days post-op following an emergency laparotomy for a diverticular abscess. He has a past medical history of type 2 diabetes, hypertension, and he's morbidly obese, weighing 125 kilos. You can place your A to G assessment here in A for assessment. And part of your R for recommendation is, can you please review Peter? I am concerned about his low urine output and the cool peripheries. And if you are concerned about a patient, that language of saying I am concerned is very important to communicate it as part of escalation. Now, this might be in case you feel quite confident in the progression of events. This question is a little bit more advanced, but it's good to sort of consider as part of developing your understanding. So these options outline some of the possibilities of what you as the RN can expect the JMO or the intern to do. So the junior medical officer is likely to do one of these options following your ISBA handover. They could request to push oral fluids and perform a bladder scan, and then insert a urinary catheter again if the scan volume is high. They could commence a complete assessment of Peter, including an A to G assessment, and then review his healthcare records. They could request to give Peter a fluid challenge of 250 milliliters to see if his vital signs improve, and repeat this observation in 1 hour and inform and they would want to be informed of the results. Or would they review Peter's observation and medical records and outline a monitoring plan and request some pathology tests? Sometimes it helps to know what you could expect in a clinical situation such as this. So in this situation, the JMO will need to complete a full assessment of Peter in order to identify if the change in his condition reflects deterioration and to identify any other possible causes of the low urine output. The reason why the first one isn't correct is because a complete assessment of the patient is required in order to, again, identify if the change in his current condition reflects any deterioration. And that's why the last two are also not the most correct answer. So based on the junior medical officer's evaluation of the patient's condition, they did conduct their own physical assessment, doing A to G, which involves A to G, and this confirms your similar findings as RN Andrew. They also take into account the results on the vital signs chart, the SAGO chart that you collected, and they decide to prescribe an IV fluid bolus of 250 mils to 500 milliliters of normal saline to review the pathology results and to plan to review the patient again. So they're administering a fluid challenge and reviewing the patient's response following this. That way, reviewing the patient's pathology results will help to look for other signs or causes of the low urine output. What is expected at this point is ideally Peter responds to the fluid challenge and passes 100 milliliters of urine at least. They will then do their own handover to the next medical officer responsible for Peter's care about what treatment has already been implemented from their end of things. At this stage, the junior medical officer would call their registrar to review the patient if they are unsure if they've done the right thing and if they need advice before implementing the plan. So Peter responds to the fluid challenge implemented by the intern and has passed 100 milliliters of urine. They return to review Peter approximately 2 hours following the clinical review. They conduct, as part of their physical examination, an A to G assessment, and he's prescribed an IV fluid regime as part of maintenance fluids. So they're now going to keep him on maintenance fluids. So from their point of view, no escalation to the registrar is needed by the JMO to review the patient further at this point. So they were, if they were unsure of the treatment plan as an intern, they would need to call for advice from the registrar before implementing it. But they've been able to solve the immediate problem, and they'll be able to do their documentation and hand over to any other person who may be called for a clinical review on the same patient. So, as you can see, a bit of closure after the clinical review. His condition improved after and following the fluid challenge, and then that way no further treatment was necessary. He spent another few days in the ward and then was discharged home. So overall, with this presentation and the use of the case study, you've been able to work through identifying, assessing, and responding to a deteriorating patient with regards to a fluid imbalance. And it's a very, basic example, and one that hopefully, you've been able to start with your A to G, applying A to G assessment lecture, and the content in this lecture, and start to put pieces of the puzzle together and hopefully become more proficient and confident with actually putting a lot of these very theoretical concepts into practice. And again, this is all to prepare you for your eventual clinical placement and registration as a nurse. It also helps with that last portion about what you could expect from the medical officer side of things. It just helps to keep in mind what you could expect next to happen to a patient, especially when they're deteriorating. Often junior nurses just think, if I do this, what will happen? So this hopefully gives you a little bit of insight into that. And it's also a good way to practice using ISBAR, because I know a lot of you want more practice at that. So hopefully also in your labs each week, you can practice that with your tutor. I know we're quite limited this year because of COVID that we're doing 1 hour labs, but hopefully with the theoretical explanation and preparation for your lab sessions being online, you can watch that, watch the procedural video, and then go into your lab really prepared to make the most of your 1 hour session with your tutor. So thank you for listening to this presentation. Please let me know if you've got any questions. You can always email me, or you can place your question on the discussion board, and the teaching team are monitoring that discussion board throughout the semester. Thank you.